to Dr. Hester to follow the school rules and sit and prepare for the presentation. Can't hear you. You can't hear? Can you hear me now? So good evening and welcome. My name is Shannon Powell, and they have asked me to moderate tonight, which hopefully will be the easy moderation. But the group asked that I do thank you all for coming and recognize that we all come from all walks of life with all thought processes. We're along a big spectrum. Some people more government, some people less government. But the idea for tonight is to really have a community forum that discusses federal funding impacts, where we might be, where we are, and where we need to go. And again, thank you all for coming. As all citizens in Nelson County, we all look out for one another. We're respectful of one another. And so as we go through tonight, we just ask that you open your mind, you listen. If you have questions at the end of the 3 presentations, we will have an opportunity for some Q&A. We ask that those questions do be focused on the presenters, the information they presented, and we will go at that point. So we're going to start the evening out with a presentation and discussion from Dr. Amanda Hester, who is the current superintendent of Nelson County Schools. But again, thank you all for being here.
Good evening. Can you all hear me? Yes. All right. Usually I don't need a microphone, but I will make sure I try to speak directly into it. I do have about 10 items that we kind of anticipate that could be addressed with any kind of potential adjustments coming from the federal programs. And so what I want to do is talk about the 10 possible items and give you a little bit of detail about each one of them. In education, we're really bad about throwing acronyms out or talking about something, and it's very normal for us and it's everyday language for us, but it's not common language for everyone else. So I will try to make sure that I speak slowly, clearly, but also detail enough. Is that me? Okay. All right. So the first thing, we have several titled programs. You'll hear us talk about that a lot when we talk about federal funding. There we go, and education. And the first title program that I will talk about is Title I. Is it too loud now? Okay. We're going to go back and forth for a little while. All right. So Title I refers to a federal education program that's designed to address and support low-income students. In Nelson County, we have 2 of our schools that participate in the Title I program, and that's both of our elementary. And really what it does is it provides supplemental resources and support to these schools, and it addresses educational needs of students at risk of falling behind and struggling to meet the state standards and academic standards. What we use this money for, we get about $512,487 from the federal government. So over $500,000. And what we use it for is to pay the salaries and benefits of 3 reading specialists, a reading interventionist, and a reading coach. And the reason why that is so important is about 2 years ago is the passage of the Virginia Literacy Act, which requires supports in literacy and requirements of specialists and interventionists with ratios of student ratios. So that's really important to kind of keep in mind. It also goes to contributing to a director of instruction salary. We use a small portion of this for staff development. We have a slew of training and mandated trainings and mandated professional development that is expected, so we need to find ways to be able to support this. So that's for Title I. So again, that's at risk. Title II is more specific to quality and effectiveness of teachers, principals, school leaders, and that falls into a lot of different categories, not really going into deep detail other than we get about $72,193 from the federal government. Again, it does help to address low-income minority students with access to effective teachers, increased number of teachers, principals, and school leaders effective in improving student achievement. As we all know, coming out of COVID, we are working to try to recover any losses and continue to move forward. We're really pleased with the strides we've made so far. We still have a ways to go and continue to improve. Increased student achievement consistent with challenging state academic standards. So the focus that we see with Title II is where we have about a half-time teacher, we call them full-time equivalents of a math coach's salary. benefits and tuition reimbursement. In an age where we're seeing fewer and fewer individuals go into training programs for education, we're receiving professionals that may not have the background and training that they used to, so it's super important to be able to provide the professional development as well as tuition reimbursement for those looking to expand their endorsements, but also get the background foundational skills in that. Title III, we receive about $6,000, and that is a program designed to support our English language learner students. With the new accreditation model that we see coming forward from the state that has the influence from the nation, it used to be our English language learners, or we call them Ls, would have 11 semesters. If you have 11 semesters of English literacy instruction, your SOL testing would then qualify to be included in the accountability. The accreditation model has changed, and it has dropped that requirement to 3 semesters. So our students coming to us that may have 0 language skills will have 3 semesters to then develop the skills, knowledge, and ability to pass our standardized tests. So those Title III monies go to help support materials, supplies, training, and being able to support those students. And again, that was for about $6,000. Title IV is about $40,186. Student support and academic enrichment. So this is where we're going to improve our academic achievement. We put this towards some behavioral supports for our students. Starting before, but really exacerbated through COVID, we've started to see increased behaviors of our students, particularly at the younger ages. So through this grant, we help to, we use a portion of it to pay the salary and the benefits of an in-school suspension assistant at the middle school, which allows kind of that removal of a student temporarily from a classroom to be able to work with them and regroup behaviorally. And then also it goes to an instructional assistant for the alternative education program at our high school. Again, more specifically to support some of the behavioral that also leads to the academic supports. Our Title VI-B, this is where you hear a lot of it when we're talking about SPED, special education students. So this is a grant that's more specific to students with disabilities, particularly as it relates to support services and providing related services that we are mandated to be able to provide. Things like that would be support direct services, technical assistant, personnel preparation. We have a portion of our salaries and benefits of about 8 special education teachers, the director of special education and student services, and then also our SPED assistant. We also use it to, again, pay for some of those support services that we're legally required to do, but also in that needing to do to support our students. We also see some of the preschool grants. It's Title VI-B. I know it's a lot of numbers and a lot of letters, but this is more of the preschool. We have preschool grants. The importance of our preschool is it is the opportunity for some of our at-risk, economically disadvantaged students to have that access to learning, understanding the education system, access to health. When you're in our schools, we still provide screenings. We provide a lot of opportunities that are necessary for those students. It also goes to extended school year services and materials and supplies, and that comes at about $14,535. Medicaid, and you'll hear some others talk a little bit more in depth about Medicaid and the possible adjustments to that. We receive about $88,146 from the federal government for Medicaid. And how we use that is for physical therapy, occupational therapy, speech therapy, audiology, nursing, psychological services. I spoke before, we saw a lot more mental health and behavioral concerns with our students. And we use, and our families use that Medicaid opportunity to pay for some of those mental health supports. And I think that that's something that we really want to keep an eye on. You hear a lot of conversation about Head Start. It is a preschool initiative. We have kind of 2 preschool programs operating in both of our elementary schools at the same time. We have the Virginia Preschool Initiative, which I just spoke about, but we also have Head Start. It's not really funded directly through us, it's through a separate program, but it still serves our community children and our at-risk community children. And so we have about 40 students in those programs at both of our elementary schools, and that's socioeconomically centered when it comes to those students. And we also have something called E-rate, and I don't know how familiar many of you are. E-rate, the Supreme Court just heard a court case March 26th about E-rate and the legalities of it, and they'll have a final decision come out maybe late June or July. But really, how we use the funds, and we get about $112,400 for E-rate, and that goes to our telecommunications and our internet access. So at each of our sites and our locations, we provide for most of what we do, and some of the mandated access points for operating systems and things of that nature require internet. And also to be able to provide our students the best pathways to be successful, they need that access. And so at each of our sites, we have to be able to provide the internet access, the communications. It also goes towards updating a lot of that. Like I said, that's about $112,000. Each of those grants are tied to our sites. So that's important to also remember. That's where we get our broadband, internet, and firewall services. Carl D. Perkins grant, you'll hear a Perkins grant quite frequently. That is tied to a CTE. So we get about $39,000, $165 for our Perkins grants, and that goes to support our career and technical education. Used to be known as vocational types of access and classes and skills. And so that helps fully develop the academic side of those skill-based competencies and classes. Vocational programs at both our middle and our high school benefit from the Perkins grant, and that's how we're able to purchase CTE equipment, also materials, and also provide the professional development for those items. And last but not least, our community eligibility provision. Most of us are familiar with the National School Lunch Program. You'll hear people talk about like free or reduced lunch. Well, that's one program that's provided by federal government, but there is another, CEP, and that's what we currently participate in. What that does is that allows for all of our students who go through our line free breakfast and free lunch. You don't have to fill out the applications for free or reduced. We participate in this, and the reason why we're able to participate in this is we have a level of socioeconomic and economically disadvantaged students. Currently, the threshold to qualify to participate in the community eligibility provision is 25%. We have our lowest qualifying schools at about 50%, that's our high school. Our highest qualifying school is at 59%. The reason why I bring this up is there is legislation out there looking to adjust this threshold to take it from 25% to 60%. If that threshold were to be made to 60%, we would not have any of our schools qualified. So then we would need to look for a new pathway to be able to provide those breakfast and lunch services. And we've, the NCPS has participated in this since about 2020. COVID. This program has been around, I think the law was passed in 2010, so it started in 2011. We just began to participate because we weren't qualifying up until that point in time. So that's something that we really want to keep an eye on. If there happens to be any kind of adjustments, whether it's in legislative actions and funding actions, we want to just make sure we keep an eye on that to see how we would need to respond accordingly to that. And like I said, our highest ECD rate, or economically disadvantaged rate, is at one of our elementary schools at 59%. Lowest rate is at the high school. Not unusual to see the rates drop as you get to high school due to various reasons. So that's something that we really want to make sure we keep an eye on. As we know, it's hard to learn when you're hungry. Most of us don't function very well, but that's something that we just want to keep an eye on. Those are the 10 items that we really are wanting to make sure. I will say that information that we get from our contacts, we have partnerships that we work with and individuals that work with the federal government, state government, are indicating that they feel like there's a really good chance for Title I, that's the at-risk title grant that goes to our at-risk students at both of our elementary schools. Title IV, that's what we help use for our behavioral supports at our middle school and our high school. And then also our SPED monies that we feel like there's a good chance that there may be that funding there for this next year. So that's what we're hearing right now. Obviously, we don't really know. We receive these monies from the federal government. About 25% of this money comes to us on July 1. The reason why state fiscal year starts July 1, the federal fiscal year starts October 1st. So there's a little bit of those gaps that make it interesting to try to bring all of this together and understand the full impacts of things and when we'll really have a strong understanding and answers. But that kind of is where we are. We feel like that's pretty good news to hear that there's a good chance to have Title I, Title IV in the SPED funding. It's where we start to see some of these others that right now we're paying attention to, looking to see if there's any adjustments. And if there's adjustments, we look to see how we can respond accordingly to be able to support our students and our staff to the best of our abilities so they can be successful. So thank you very much for allowing me an opportunity to provide some information about this, and I will pass the mic on to the next speaker. Thank you very much.
Thank you, Professor. That was great information. So our next speaker is going to be Mr. Rodney Johnson. He's a hometown hero, and he is the CEO of Blue Ridge Medical Center.
Hello there. Everybody hear me? Perfect. As Shannon said, I am a native of Nelson County. I grew up here. I've enjoyed being home. I love Nelson County, and I refer to it as God's country. I also remember a time where, if you've been around, there was only 2 to 3 physicians within the county. And Dr. Rayner was my provider. He delivered me. He saw me all the way through high school and college until I left. I had grandparents who went to Dr. Smith or Dr. Gamble, and that was it. So we were limited. Around 1984, a gentleman had this great idea to figure out how to bring FQHC, a federally qualified health center, to Nelson County to support the rural health programs, to look at the underserved, underinsured, how to help the county. 1985, that vision came forward in a small modular building. 40 years later today, we have a very large presence up in Colleen on 29, and we are proud of the work that we do to serve our county and our community. Thank you. We have grown to provide services such as primary care, behavioral health, dentistry, and we have one of the only pharmacies in the county that is actually open on Saturdays. We continue to be proud and state funded, and we rely on those funds to continue to grow our programs, but to sustain the current programs that we have today. Last year alone, Blue Ridge Medical Center in Nelson County saw over 10,000 patients. Those patients turned into roughly about 25,000 visits throughout the year. The breakdown of that is about 22% of our patient population is Medicaid, 33% is Medicare, and about another 22% are individuals who either do not have health care or who some form of subsidized health care and without it would not get care. So for Blue Ridge Medical Center, anticipating funding cuts is a little concerning, but it's also worrisome about how we're going to continue to provide our services and how we continue to support the communities that we're in. We already know that when individuals don't have access to care, they either prolong care, they put the care off, or they find themselves in an emergency room, whether at UVA, Sentara Martha Jefferson, or even in Carilion, that the ERs are going to get overwhelmed. Some individuals with chronic care, if they put it off too long, sometimes treatment is not enough, sometimes life expectancy gets cut short. Having preventative medicine is key. And in rural Nelson County, it is essential that we have access for these individuals. We do not turn anyone away, regardless of their ability to pay. We accept all, and we support and we give them the quality of care that they deserve and that they need. The impact of federal cuts on Blue Ridge is the same impact that will be applied to any healthcare agency, large or small. The larger organizations, as I mentioned, UVA and Sentara, they could probably absorb those losses a little easier. A small FQHC, such as Blue Ridge, we won't. So for us, when we start looking at funding cuts or any loss of funding, how do we make that up? How do we come up with those funds? The impact will be looking at either reduced hours for access, a loss of providers who are looking to come to the county to do rural medicine, or a reduction in staff. That would increase wait times, that would increase access. That would definitely cause individuals to probably not seek care because it is just, nobody wants to wait in a waiting room, nobody wants to sit or be told you can't get a visit for 6 months. That is just not going to be sustainable. When we think about our services that we offer the key services that our community needs. When we talk about grant and grant funding, part of what we have to do is provide not only a justification for that funding, how we plan to use that funding, but how does it benefit our community? And again, our focus is on preventative medicine, primary care, dental, and mental health. So without those services, we do see a decline. And with cutting services, we just see more and more decline in individuals seeking care. And again, many would just not seek care. It is costly. Healthcare is not cheap, and to run a healthcare practice is not cheap. But when patients start going to the emergency room for primary care, the cost goes up. Not only financially, emergency rooms get overwhelmed, they can't keep up. By the time someone does get care, it's escalated to the point where the cost is astronomical. Where if they were started at the very beginning, or if that illness was caught at the beginning, the pace and the treatment plan is less expensive. So it's important to remember that as though we may be cutting costs to save on one end, we're going to pay for it on the other. And sometimes it is paid in monetary, or it could be paid in life. Loss of jobs is something that worries me tremendously. Blue Ridge Medical Center employs 125 people of Nelson County. These are individuals who look to us to not only provide them a career, but an award or an emotional strong place, a place that they enjoy being and gives value to them for serving our community. If we had to make cuts to offset some of our losses, we have put people into unemployment. People who are out looking for jobs. Many will have to go out to further distances, Lynchburg or Charlottesville, some to the other side over the Waynesboro, try to find employment. And with that comes all sorts of burdens, from childcare to gas costs, looking at just being able to sustain the quality of life that they've grown accustomed to and they enjoy what they have here in Nelson County. So for Blue Ridge, it's important for us to continue to be able to show our support for our community, but also to be able to have funding to continue to move forward. We do have plans to continue to support. We will be here. This year is our 40th celebration. We're going to continue to be around and for another 40 plus years. So for us, it's more of looking at stability, being able to continue to provide our services and meet the patients that we do halfway, provide the services that they need. We know there are other services in the community that is leaning towards Blue Ridge to help. We're looking at food pharmacies. We have individuals who at times don't have enough to eat. We're looking at opportunities to take care of that. We're looking at opportunities to take health care to the people. We have individuals in Nelson who have transportation challenges. They can't make it to us. So we're looking to take health care to them. So all of this would be supported through our community support. It's also funded through our government, our state, but it allows us to continue to grow and to support the needs of our community. Thank you, appreciate your time.
Thank you so much, Mr. Johnson. Our final speaker for the evening is Mr. Michael Cook. He is a partner and co-chair of the healthcare group Wiles Parker. He's a board member at Blue Ridge Medical Center. He's also very active as a former co-chair of Virginia DMAS.
Good evening. It's a real pleasure to be here. As Shannon mentioned, my name is Michael Cook. I've been practicing healthcare law for about 50 years, which should give you some idea of wondering why I'm still on the right side of the grass. And at 42 of which have been representing private hospitals, nursing homes, practitioners and their associations. And the first 7, as a young kid, I was an attorney at Department of Health and Human Services in the federal government, representing the federal regulators of the Medicaid program. More recently, until May of 2023, I served 8 years on the board that oversees Virginia's Medicaid program, the last 3 of which is as the chair of the program. And I'm currently fortunate, as you can tell, having heard Rodney, I'm fortunate to serve on his board. It's it's a gift, an opportunity, especially with someone of his incredible skills. I'm going to talk about the significant cuts that Congress is considering for the Medicaid program right now and the manner in which they will certainly will impact Virginia and you. The top line numbers of the House budget that include anticipated cuts in the Medicaid program of $880 billion over 10 years, or $88 billion a year. The members are now working on the specifics of how they get there. It's not easy. You can't do it without really hurting the program and the people who rely on it. They expect to have, or hope to have, a bill on the President's desk from the House and Senate by the end of May, and they're working on it now. The $880 billion is 10% of the federal Medicaid spending right now. So you're talking about a real major hit in Virginia if it goes through as they're talking about now. And I say if because the leadership just received a letter from 12 Republican members telling them that they can't go forward with something that does this much to the Medicaid program. So my hope, and recognizing that there are changes that you can make to the program, as you can in just about any program, and should be looking at those. In 10 minutes, I can't really hit, or 15 minutes, I can't hit everything that's being discussed, but understand it's still pretty fluid. The ways that they're looking at going about this are change with time. I can also tell you that recently I was lucky enough to spend some time with 3 state Medicaid directors, different states, 1 blood red, 2 purple, 2 Republican governors, 1 Democratic governor, 2 Republican legislatures and 1 Democratic legislature. And if you think that this isn't a bipartisan concern, each one of them was absolutely despondent about what they were thinking about doing to the Medicaid program. They all come at it in a different way, whether you're conservative or liberal, but they all care about the programs. They learn from each other, and they're real pro. And the ones I spoke with are absolute pros. So first I'm going to give you a little quick background on how Medicaid works. It's a joint federal-state program. It's jointly funded by the federal government and the various states. Each state runs its own program, and the states have they differ significantly in the country. The states have a lot of flexibility in how they do in the services that they provide, how much they pay their providers, and who's eligible, as long as they meet certain minimal federal standards. In Virginia, the feds match payments that the state makes for covered services at about 50% for the general Medicaid population. And as I'll explain later, these are generally individuals who are poor and have families with dependent children, or they're elderly, or they're terribly debilitated. And then you have the Medicaid expansion, in which point the federal government matches the state at 90% for the state, and the hospitals actually make up through a tax the other 10%. These are people who are at 100 to 138% of the federal poverty level, and it also covers individuals who are single. So unlike the general Medicaid population, it's the first time that we've been able to provide health care to a broader group of folks. It's now the largest insurance program in the country. 20% of the people of this country rely on Medicaid for their health care. In Virginia, the general population that relies is 1.3 million people, and the people who rely just in Virginia on the expansion to get their health care through the expansion are 650,000 lives. So it's basically close to 2 million people that will be affected one way or the other, depending on how they're implemented. When you have federal cuts at this level being discussed, there are basically 3 ways that Virginia and other states can handle cuts of this matter. They can raise state taxes, they can cut provider rates, or they can cut services and eligibility from the program. All of these are really rough choices, especially when you're in state government. While you may hear arguments that this is going to come from fraud, abuse, and waste, virtually none of the changes that are being discussed have any impact on that whatsoever. And that doesn't mean that there aren't some that do. And we'll see those, actually. But for example, when you're talking about fraud and abuse, the federal government has the office, at HHS has the Office of Inspector General that does both investigations and audits of providers. They also work very closely with the United States Department of Justice. They have their own health and healthcare fraud units, and they also that are very active both on the criminal and civil side. And they also have a state, what we call a state Medicaid fraud control unit in every state that works very closely with all of them. So you have entities whose primary function is to go after fraud and abuse. Also, Virginia has managed care, private managed care companies that provide and pay for the health care. And these companies are paid on a per member per month basis, whether it costs more to care for a patient or less. They also can only make up to a 3% profit level, so they've got every incentive on their side to minimize fraud and abuse. In Virginia's government actually only spends about 3% or less on administrative costs, so it's a pretty efficient group. So what's being talked about in Congress? Well, one of them is to eliminate the higher 90% federal matching rate for the expansion population. But Virginia is one of 12 states that when they enacted the expansion, they have a trigger law, which means that if they cut the 90% federal matching rate, the expansion goes away. So unless the legislature acts to pick up the difference, which by the way in Virginia would be about $3.5 billion a year, that's a huge number, you're going to have almost immediately about 650,000 people in the state who become uninsured. A second option, they're also discussing options that reduce spending overall, like reducing the federal matching rate on the non-expansion population, which in Virginia is, for states like Virginia that are matched at about 50%, that's sort of the floor right now for the general population, or setting what they call per capita, person caps on how much they will pay to the states. And that'll be done if they go that route, irrespective of how sick people are, what your patient population is. And finally, there are some provider taxes that a lot of states, frankly preliminarily red states, but Virginia also, like every state, that they rely on to provide care. So for example, we have the hospital tax to help to assist on the federal, on the expansion population. Or they can cut, they're also talking about, but these types of cuts give you about 3 choices. In Virginia, on these types of cuts, they can either reduce who's eligible for Medicaid, they can cut provider rates, which are generally, by the way, the lowest rates in most instances that providers see So they actually have to cost shift when this happens. There are a few exceptions. Virginia has something called the ARTS program, which is a nationally renowned program for substance abuse and opioid abuse. They've been able to get providers into that program by paying rates that are commensurate with with what they would get for private patients. But otherwise, Medicaid rates are usually lower than most other rates. In terms of eligibility, it's really complex, but as I mentioned, this is a small group. Once you get away from the expansion, this is a group of people that's primarily kids from economically dependent families and they're single parent usually, and disabled and aging folks. Generally at or below the federal poverty level, which is $15,650 for a single individual or $32,150 for a family of 4. There is no floor, however, if they want to cut eligibility, there is no floor for the income level that states have to cover for this population. So states could lower their income levels if they're forced to. I don't know whether Virginia would go that way or not, but it's one of the rotten choices that if there are major cuts like this, that every state's going to face. In terms of services, Medicaid only requires they're called mandatory services, and they're basically hospital, physician, and nursing home services that are required by federal law. However, most states, like Virginia, probably every state, has a number of optional services that they provide to people because they're critical to health care. Adult dental care services, home and community-based services for disabled adults, clinics like Blue Ridge Medical Center, and a host of other services that all of us who are private insurance or Medicare take for absolute granted. States, depending on how much the cuts are, that's another option for states cutting optional services. It would be very painful for Virginia and the people I know who work in that program. And that cuts across, believe me, across political lines. And in terms of lowering rates to providers, as I mentioned, Medicaid rates are generally lower than those of other payers, and further cuts would likely result in a number of non-institutional providers either limiting the number of Medicaid patients that they're going to be willing to see, or get them to pull out of Medicaid. And you find that that won't happen with hospitals or nursing homes because they rely heavily on these patients. But you're almost certainly going to see it in other areas like physicians. Also, as a former reimbursement lawyer, I look at healthcare rates like a balloon. If you squeeze one end of the balloon and lower who you're covering there and how much you pay providers there, the costs of the other end of the balloon rise because you have to make up the money, for example, from private insurance. So there's also the possibility that this affects everybody who has health insurance. And also, among other things, the increase of patients who are uninsured is going to be substantial, and almost certainly is going to cause even further backup in the emergency rooms in hospitals, and there's talk, a lot of writing in the healthcare press about the fact that you're likely to see more closures of rural hospitals, which are already stretched. So with loss of coverage or cuts of covered services, many patients, as Rodney talked about, are likely to skip getting care until it's the last moment that they need it. In fact, under the Medicaid program in Virginia, interestingly enough, at one of the board meetings recently, Cheryl Roberts, who is the director of the Medicaid program in Virginia, was talking about the fact that while we have a few less patients because of something called the unwinding, they're showing up, probably because of putting off care during COVID, they're showing up much more acutely ill, delaying care and continuing delay in care just increases that problem. Also, Medicaid covers the virtually every long-stay patient in nursing homes, elderly long-stay patients, through Medicaid. It's almost 100%. Short-term is different, that's usually Medicare, but Medicaid Medicare does not cover long stays in nursing homes. That's done by Medicaid. So these facilities are going to be hammered with the level of cuts that have been being discussed. And there's already a major shortage of healthcare workers in the workforce, as Rodney can tell you. And if you start, and right now, we have to pay more for those workers. If you stop being able to pay for healthcare workers, they go somewhere else. We found that out with the discussion that we had found a very good medical director for Blue Ridge Medical Center who was ready to start. When they started talking about these cuts, he withdrew his application because he didn't want to be in a position of working in a place that was so dependent on federal funds if they were suddenly going to disappear. And also, Congress has discussed imposing work requirements. Generally, for a whole host of reasons, they haven't really worked well, but it's something that you're probably going to see, and it's something that Virginia probably can work with. What happens with the work requirements, most of these people work if they're not caregivers. I think over 92% or something of beneficiaries, if they're not caregivers or disabled themselves or have a serious illness. And when Arkansas imposed them, they found a lot of people losing health care because they simply were, not because they were unemployed, but because they simply couldn't comply with the record keeping aspect of this. And in New Hampshire, Governor Sununu, for the same reason, paused the work requirements there. Having said that, I think that's something that you're going to see, and I think that's something programs can survive. It's going to put a little more pressure on Virginia to make sure that people who are working understand that they've got to submit the proper paperwork. And frankly, that's on us. Make sure that the process works. I think that one is almost certainly going to happen. But as I mentioned, in the context of all these cuts, I was speaking with 3 Medicaid directors recently, and all of them, whether from red states or blue states, were absolutely despondent about the magnitude and how this was being handled. And I've got a letter on April 14th, 12 Republican members in the House wrote the leadership to tell them that while they agreed that there were certainly ways to streamline the program, that they couldn't possibly vote for the cuts in the way they're structured now. One of them is Jen Kiggins, who is a nurse practitioner with a federally qualified health center in her district, and she understands the impact of these things. There is time to get your cards and letters if you feel that way to your representatives. All of them. You can also show up at town halls. If you feel differently, that's fine too. You ought to let them know that too. So at any rate, I'll be happy to take questions, and I really thank you for the opportunity.
So thank you, Mr. Cook. That's a lot of good information. Our fourth speaker was Mr. Burdett, who was unable to join us tonight, but he graciously pulled some information together and shared that with you all. I think you got a copy as you came in. So our speakers have graciously said they would entertain questions from you all. What we ask of you is that you leave those questions less than a minute, and you ensure that it pertains to the topics that they discussed tonight. And I believe Jesse Rutherford is going to have a mic, and Dee Shaver will have a mic. Sure. If you do have a question for any of our speakers, please raise your hand, and they will come to you with the mic.
All right, this side first.
What more can we be doing besides see that the president has a tendency, when he gets a lot of pushback, to change his mind? Is there something we can do in force to make that happen?
Again, I think the major things that you can do are to let your legislators know in time, before this becomes a reality, how important this is to you. These folks generally respond to voters. Letters are one thing. Showing up at town halls is important. If you have friends, speaking to your friends about what's happening. And frankly, supporting members of the other party, if that's where you are who have the courage to, because it's not easy to buck leadership. It is a very hard thing. It's easier to do with 12 though than one, I can tell you that. And it's courageous, and these folks deserve, hopefully they'll be able to prevail and shape these quite differently. But that's how you handle it, and you also support the people who are supporting addressing these cuts. You can also donate to your local hospitals.
I think to add to Mr. Cook's point, no matter what side of the aisle you sit on, left, right, continue to communicate with whoever your leaders are. So let's ensure we know that. Second question.
Questions on this side? I saw a hand over here earlier.
I was recently taken off Medicaid, and I had the extra help. And when they did that, they took part of my Social Security to pay for the difference in the insurance. The reason they took me off of Medicaid is they told me that I had one too many cars and two too many acres, and my property was paid for. And I just couldn't figure that out when I really needed it. So I had to go to UVA and apply for extra help as well. But I had applied for and but the excuse was taking me off of Medicaid was I had one too many cars. My cars are 40 years old, and I had two too many acres. And that was the excuse. And then I know that they extended Medicaid through the COVID period, but I was on it 2 years before that. And then they come up with that excuse.
Okay, so let's let Mr. Cook give advice on that one, or you may be the person of the hour.
I think my only suggestion on advice would be, there is actually a woman who is very good, Sarah Hatton, on Medicaid eligibility in the central office up there. If you can get a hold of her, she's usually pretty accessible. I would give her a call. She'll probably refer you to your caseworker, but she may also be able to give you some thoughts on what you can do. They have every state has limits on the resources that you can have for eligibility. As I say, if these cuts go through, there'll be a lot more than that. But I'd call her and I'd talk to your caseworker, and I'd go down there in person and say, hey, look, I've been on Medicaid for 2 years. You're going to increase your hospital costs. What can I do? And why in God's name is 2 acres something that's going to put me on resources, because it's resource amount. And I think talk to them about whether or not you can work the resources down in some way. But I'd first, honestly, if you can get a hold of her, you're free to tell her that I suggested you give her a call, which means she'll never answer mine again. But her name is Sarah Hatton, and she's really good. And if you want to give me Sarah Hatton, and let me give you my email address, because I'm happy to try and... let me give you my email address, because while I don't do this kind of law, I do have Sarah's email available, and she really will never speak to me again. But my email address is mcook, C-O-O-K, at Liles, L-I-L-E-S. Oh, okay. Cook, C-O-O-K, at LILESPARKER.com. Sarah actually was the person we had, you mentioned about the COVID issue. They couldn't, the state, all the states got an extra 6% matching rate if they agreed not to take anybody off of Medicaid during the public health emergency. And when that ended, they had to go back and do eligibility determinations on everybody who was there on Medicaid, and that's probably how you might have gotten flagged. So Sarah's very good at figuring these things out.
The whole question is, are they giving special aid to any illegals that are in this state?
No, they can't. They can't. Medicaid doesn't cover illegals. I will tell you one thing though. One of the frustrations that you can run into with that is somebody who is illegal, when you deal with healthcare, somebody who is illegal, if they don't get healthcare, walks around the community sick, and they can give it to others. So getting healthcare is not only important. You don't give out benefits in healthcare just for the person who's getting them. It affects the community at large.
Any other questions? Please raise your hand.
Hey, good evening. I just pulled up the national debt calculator. We're $36 trillion in debt as a nation, which equates to about $323,000 per person. I know Social Security, its public record, is going to go insolvent in the next decade. We're on track for that to happen. With those things in mind, obviously something fiscally responsible has to happen with our nation, wherever you stand on that. So with those things in mind, what parts of these proposed, emphasis on proposed budget cuts would you, each of you in your respective fields, support and think are a good idea and fiscally responsible, not just for us, but for our children, my children, grandchildren, because in the next 100 years, you know, $36 trillion is not sustainable at all.
Okay, so we'll just start with you.
Oh, God. Yeah, you're not going to solve it with just these cuts. It's a lot more complex than that, and unfortunately, they came close when Boehner and Obama talked about. They put together a commission, the Simpson-Bowles Commission. Simpson being a former Republican senator and Erskine Bowles being a businessman on the Democratic side from South Carolina. They came up with some pretty difficult, politically difficult, I should say, solutions. They came close, actually, to getting there, but they couldn't sell it to their members who have to run. But types of things you can do, and they're not going to be easy, and I couldn't agree with you more that 36 trillion is not sustainable. It would be a combination of tax increases on people who are wealthier. It would be a matter of taking a look at Social Security as we live longer and perhaps raising the age of Social Security, and possibly doing the same thing for Medicare, although there you'd want to means test it and make sure there was a backup for folks who didn't have the money. A package of that nature, there are a lot of tax loopholes. There are also a lot of taking a very close look at your expenditures. An example, if you run a business, you'll frequently, if you need to look at your expenditures, you do almost a bottom-up analysis. Here's what we're looking to cut. Give me your suggestions as to how you can do this. If you can't meet our goals, then you better give me a good excuse why you can't and asking for a waiver. And that's a thoughtful way of going about it. But you are probably going to have to raise, and this is a real political football for younger people. If they wanted to, you're going to have to raise the ages for Social Security, certainly, and possibly for Medicare. You're also going to have to lift the caps I don't remember whether Social Security's already lifted it. I don't think Medicare has. On the tax that you pay on these. Right now, I think you pay up to a certain income level. Certainly people with higher incomes can afford the increases that would occur just having your entire, as people who make less have their entire income taxed. So to taking a look at that. But these are hard choices. They're politically hard, and they haven't yet reached a point where they can do it. You first of all need a commission like Simpson Bowles today that's bipartisan and completely aside from Congress to start looking at and start looking at these at the expenditures and the deficit overall. So I don't think it's on a bumper sticker, and when you try to do it off of programs willy-nilly instead of looking where you can make reductions intelligently, you're going to get ugly results.
So I believe in addition to what Michael had mentioned, from a healthcare perspective, we are living longer. We see that each year you can look at statistics and see that we have longer life expectancy. For me, I believe one of the areas to look at is preventive medicine, starting early, working with children and looking at environmental studies. So I think if we look at preventive medicine, we're keeping people out of the hospital, keeping them healthier longer. I think that will go a long way. It's when in healthcare, the aging population or any population are starting to use the hospital, for example. Many of their studies, many of their bills are much more expensive. And many individuals at that point either fall into a financial challenge or they are dealing with situations that could have been prevented early on. So I believe for healthcare, preventive medicine is starting early and looking at everything from the environment to genetics to modern medicine and research. So for me, it's more starting earlier and preventing those hospital visits and reducing the cost in that area.
Can I add something to that, Rodney, very quickly? In North Carolina, the Medicaid program actually ran some pilot programs where they made sure that if you were on Medicaid, that you got referred to places for healthier food, that you got referred to places for better housing, and lo and behold, they just had an outside, because I was on a panel with Jay Ludlam, they just had an outside actuary take a look at that, and while there were a couple of upfront costs, the actuary discovered that they were actually saving money on their healthcare expenditures. We're starting to cut that. That's a mistake. These are the types of strategies, how you deliver healthcare, that are also showing some promises.
So I don't claim to have that full grasp of every possible elimination or adjustments to the entire national economic system, but I will say this is my 22nd year in education. So I started around 2003, and every year the responsibilities that are now put back on the schools, whether they're the teachers, counselors, nurses, what have you, is greater. And ever more so in recent years, and particularly in small and rural areas, just due to a lack of access to a lot of other services. And I will say that if you take a look at the role of education, when you have a higher educated citizenry, it's more productive. You have a more productive workforce. You have a healthier population. And then, as you just suggested, if we're living longer and we're healthier, then we're going to be contributing more back to society and back to lives. Ultimately, that's contributing to the GDP. It's contributing to the overall economic system, and how, whether it's national or we take it providing greater innovations to contribute globally. And what that can do is then ultimately full cycle come back and maybe require less of the other services because you're contributing to a healthier society, higher GDP, so the greater services, and kind of that cyclical opportunity to address some of these things that, breaking the cycle of generations, of whether it's generational poverty or health. And that's not an overall solution to everything, but I think at the end of the day, these are our children. I can't speak for all the other aspects, but in the least, we should be dedicating everything that we can to our most important part of our citizenry. And these kids, they need us, and they need the supports and the pathways that we can provide for them to have an opportunity to be successful, to be healthier, and to be positive contributing citizens to not only Nelson, but to the Commonwealth of Virginia, to the United States. It is a cycle, it is a big picture. In Nelson, we talk about the theme of one Nelson. It takes all of us, and it really does. It takes all of us to help our students be successful, but it takes all of us to help us maintain our niche here, our world, our culture, our place. We live here, we work here. This is where we want to set up the most ideal opportunities for, for me personally, whatever pathway our students want to take, whether that's career immediately, college, and just being life ready and being healthy and having opportunities that they can pursue. So I see that how it's a cycle. There's no easy fix. You cut one way, we talked about the bullying, you cut one way, it's going to be a pull and a push somewhere else. But you sometimes have to invest early and often in order to see it pay out later. And I think with our children, that is a strong investment for us, and it is investment. And we owe to do everything that we can to support them. So I appreciate that. I think that's a great question. It's very thoughtful, and it's complicated. And I can just say, selfishly, you start with the education piece, and it'll help contribute to solving a lot of the others. And it all works together, though. So I appreciate that.
Any other questions?
Here.
If the Medicaid expansion program in Virginia is terminated, then the Blue Ridge Medical Center, do you get any good care funds from the state, or how would you provide care for your patients?
So if the Medicaid is cut?
If the people lose their coverage because the expansion program is terminated, and you're going to have a lot of people who don't have insurance.
Correct.
Your patients, do you get any care funds from the state, like the VA hospital?
No, ma'am. No, ma'am. So in that situation, we would anticipate roughly about 22% of that patient population would probably not seek care at all.
So they have to come to like UVA where
They would probably go to UVA or somewhere else, or not receive care at all. Many would probably go into a self-payment plan, and depending upon the cost, some will be able to make those payments, some will not. So it really does determine the individual of how they want to invest in their care. Now, we will continue to provide care and do everything we possibly can to support them, but if they do lose their Medicaid benefits, it would be a struggle for them.
Right.
Now, hopefully, we will be able to, and any other medical group will have some form of reserve or an opportunity to help offset that cost. Or if that is the case, hopefully the government or someone in those positions will look and say, okay, we've got to still be able to provide you some source, but as of right now, I'm not aware of any conversation around that line.
Repeat the question before they start answering.
All right, who has a question?
Just a couple more questions in the interest of time for speakers, but let's get
assistant program. That individual can either help and guide them, or that individual can also connect them with the pharmaceutical company that could also offer additional support.
She has talked to other people. The problem is part of it is her ability to completely understand. It's difficult.
If she could have a patient advocate to support her and speak on her behalf, that will be the greatest thing you can set her up with.
Where do they get that?
That can be anyone. That can be a family member, a friend, anyone who is willing to support them, and just go with them either to their visits or have these conversations. It's just a person who's volunteering their time.
One of the medical things that I tried to encourage her to pursue is actually, I can't remember his name, he owns a ball team, and he has some kind of program.
Mark Cuban.
Yes.
Mark Cuban.
They didn't have one of the major medications. So they were
Yeah,
stopped.
no, he's looking at finding a way to more efficiently and less costly by buying or producing in bulk. And for that, you have to generally go to you don't go to the orphan type medications. But the if they have a program like this, the manufacturer of that particular drug may very well have a patient assistance program, and it is certainly worth exploring.
I'll add a little bit to that just because I've got a little experience in this, but if you work with whoever her physicians or her practice group is, they should be able to give you some guidance or give her guidance on how to communicate with the pharmaceutical companies and how to go about that. Any other questions?
More an observation than a question, really. Doge, I'm sure you're all familiar with Doge and the corruption and the fraud and everything else that they're uncovering. One of the things that tends to happen with government-funded organizations is that they become administratively heavy, where the funds are not going to the intended recipients. They're staying more at the top level, where the administration seems to get bigger and bigger and bigger. And I would suggest that would be the first place to look to cut if there are reductions from the federal funds that are coming to the organizations.
Sure,
And that's just another
Virginia's Medicaid program, they have a very low administrative cost. It's very low. It's something like 3%. And the Medicare program's overhead is a lot lower than most insurance programs at 3%. But if you're in a business and you have a budget issue and you want to take a look at it, I mean, when I was on a health reform commission, and one of the things in Virginia, and or I should say on a work group, and one of the things that amazed me as we were going through this is they had little programs. A particular legislators helped start little programs that gave a very little amount of money to people, but they were duplicative. And what would have made sense would be to have somebody take a look at these programs and say, okay, if I can pull this all together, one, I can do it more administratively simple, and secondly, I can give a much more useful benefit doing the same thing. I think when you go take a look at government, you'll find some of that. Anybody who tells you there's no waste in government is dreaming. But the way to go about it isn't to willy-nilly cut folks, many of whom are your researchers, for example, who are working on dementia drugs and who got cut at NIH. It's to go to and frankly, if I were secretary of a department, I wouldn't want somebody who didn't know a damn thing about my business just coming in cutting. I'd say to them, okay, give me a number, tell me what you need, and I'll see if we can meet this. And then you go down into your staff. It's not something that happens in 20 minutes. You go to your staff and you talk to them, and you find and make sure they report to you. Do we have programs that are simply duplicating each other? Do we have programs that are not terribly useful? Where can we make the cuts intelligently? You do that with any business. That's not what's happening right now, and you'll pay for it.
Thank you to our speakers. I think we have time for maybe one more question. Margaret, did I see your hand?
I did. I don't think I need a mic. I just wanted to say thank you very much for putting this together, because I think that everybody has, well, I'm going to speak for everybody. I think it was very informative, very even-keeled, and I know it, all these things are kind of still up in the air, and they still could have an effect on Nelson. And so that was my question was, do you guys have a sense? I know I was talking to a lady who does speech therapy, and all of her patients are Medicaid patients. So she's like kind of thinking, what's going to happen to my business if something happens to Medicaid? So do you guys have a sense of how we might be impacted in the county in terms of job loss or companies that might be affected? I know that in the school system, some of those title programs provide the funding for the individuals who are working those jobs. So I just was kind of get a sense of how our county might be affected from a job perspective.
So for Blue Ridge, again, we really don't know what the impact is going to be as of yet. We can just create all various scenarios and hypotheticals. We can look at, all kinds of graphs and charts and history data. So for right now, my plan is I am looking forward. I am planning for the worst, but hoping for the best. So for Blue Ridge, worst case scenario for us, looking at what we hear going on Capitol Hill and at both federal and state levels, and some of the things that are being tossed around. For us, a impact to Medicaid cut would hit Blue Ridge anywhere from about 400,000 up to just under $1 million. So with that, then it's now looking at how am I going to supplement that without reducing my staff, continuing to provide services and care. So part of that is looking at our reserves, how much we can pull out of that, but how much can we continue to do as a business. So for us today, my goal and my plan is to continue to keep my 125 plus employees employed and keep providing the quality of care that we've provided. And as a group, my administrative team, we've made our goal to make that for all of us. And I don't remember how many you're aware, but last year, Blue Ridge Medical Center, for the first time, received 4 awards for quality of care in pharmacy, family medicine, pediatrics, and customer service. So that speaks volumes of what this group is doing. And that is our motivation to continue to move forward. Now, if we do have to make some administrative cuts and adjustments along the way, we will. But right now, we're like that duck on the water. At the top, we look calm, but underneath, we're just kicking like hell. That's kind of where we are.
So thank you. We've had a lot of questions, a lot of good dialogue tonight. We do want to thank the speakers for their time. If you've never sat on a stage and been a part of an open Q&A, it can be a little bit intimidating, so we thank you for the respect from the audience and the questions that you all shared with us. And on behalf of the group that put this together, they wanted to ensure that we really did focus on the thank you. But as you leave and move forward from this moment, remember that really knowledge is power, but dialogue to me is more important. So if you have your voice, use your voice, whatever you want to communicate in regards to federal funding, use your voice with your appropriate people. Thank you again for coming. We really appreciate your participation.